On behalf of HealthCert Education, I'd like to welcome you to this evening's webinar. This is the 7th webinar in a series aimed at bringing value to our alumni by providing clinical guideline updates and new information to you easily and concisely with a wonderful presenter who shares relatable and interesting cases. Tonight's webinar focuses on the newly revised clinical guidelines for gestational diabetes. Before we get started, I'll run through some housekeeping and introductions. So at the end of the webinar, we have a post-webinar survey that provides you the opportunity to give feedback on the webinar and request some more information on any of our courses that might help you in your CPD journey or to subspecialise in particular areas of interest for your practice. Also, for those of you attending live or watching the recording, you may be able to apply for CPD for the webinar. And a certificate of attendance will be emailed out along with the recording and some instructions on how to self-submit to your relevant college for consideration of CPD. With that, let me make a proper introduction to Dr. Simone Gonzo. Dr. Simone began working in healthcare as a registered nurse in hospitals throughout Queensland in 2003. After making the change to medicine, she graduated from the University of Queensland in 2010. Dr. Simone enjoys all aspects of general practice, including family health, mental health, chronic disease management, and complex primary care. She also has a special interest in teaching and training GP registrars and medical students, and she's currently working on a Master of Healthcare Leadership. And with that, I'll invite Simone to get the presentation underway. Over to you.
Thanks, Campbell. That was lovely, lovely introduction. Welcome everybody tonight, and thank you HealthCert for sponsoring us tonight to look at the screening, diagnosis and classification of gestational diabetes update that was released only over the last few months. So we'll have a look and hopefully learn a little bit more on the new updates for gestational diabetes. We'll start with our acknowledgement of country. So I'm in northern Brisbane around Caboolture. So we acknowledge the Gubbi Gubbi people as the traditional custodians and their continuing connection to the land, recognising elders past, present and emerging, and also the traditional lands on where everybody else is watching from. So that's just a summary of my bio there that Campbell has detailed. So we'll gloss over that and we'll head into our learning outcomes. So tonight what we're hoping to do is determine the content of the Australasian Diabetes in Pregnancy Society consensus recommendations. So this centres basically on screening, diagnosis and classification of gestational diabetes. So this evening, we're not going to focus too much on treatment of diabetes. It's more about the early stages of pregnancy and how we stratify patients into low, high, medium risk, and also diabetes in pregnancy or overt diabetes in pregnancy or gestational diabetes, because the numbers have changed slightly with that. So we're just going to look at how we apply that to our diabetic patients or pregnant patients, and then looking at a couple of patient cases, seeing how those, getting familiar with how those guidelines apply. So moving through to the background for the changes that we'll look at tonight, there's been more of a focus on clarity, inclusivity and best outcomes for mothers and babies. The previous ADIPS guidance is actually from 2014, so we're looking at 10 years old information. The evidence that they've based these recommendations on is from more recent trials, and it reflects a more harmonised, updated screening thresholds. And obviously the main difference or the crux of the matter is the raised diagnostic threshold. So those numbers that have been increased, and some of you who may have been around for a little while have realised that the numbers did drop, or the criteria for diagnosing gestational diabetes dropped, which meant that we had many more patients to deal with. These have been revised to a slightly higher level. There's also been a more clear criteria for diagnosing overt diabetes in pregnancy, or DIP as we're now calling that, and also looking at streamlining early universal testing strategies. And tonight's information or education leans more towards that shared care with public hospitals. I'm in Queensland, so I sort of work between Queensland Health's guidelines, because that's what the patients get exposed to, but also reflecting the differences with with what the ADIPS is showing us and how we apply that locally to our patient populations. So gestational diabetes is one of the most common disorders in pregnancy. The diagnosis tripled since 2000, and those factors do include, if you look down to the third point there, the change in definition of GDM, which was when we lowered those numbers. The other factors or influence was an increase in maternal age and the increasing BMI combined with the change in ethnic diversity in the Australian population. So that's meant that we have a large cohort of patients to deal with now. In 2021, so that's only a few years ago, GDM affected 17.9% of birthing women, and First Nations made up 20% of that. Other Australian women made up 17% of that. The treatment, interestingly, I thought, even though we're not really discussing treatment, I thought it was interesting just to see how that was split in the last few years. And even though we've had an increase in gestational diabetes diagnosis, it's really only been 47% of those patients that go on to require pharmacological therapy or be prescribed pharmacological therapy. Still quite an even split. 49% just being managed with nutrition, physical activity modifications, dietary changes to manage that glucose level. So just revising our risks and complications of GDM. So trying to split this into how it affects the two patients that are exposed to GDM, so mother and baby, pregnancy, long-term, gives us a nice little sort of four-way split on ways to picture this and also explain this and discuss this with patients, because sometimes when you're talking to patients, there seems to be an understanding that GDM is only a problem during pregnancy, that once the pregnancy is finished or complete, it's no longer a problem. So patients sometimes don't appreciate that there's long-term outcomes for the infant as well as for the mother. So the adverse pregnancy outcomes, so this just focuses on the actual pregnancy, preeclampsia, macrosomia, and an increase of obstetric interventions, so cesareans, forceps, things that need to be done during the pregnancy or during delivery. Neonatal complications, so this is while the infant is in utero, so there's neonatal or just delivered, neonatal hypoglycemia, respiratory distress, and jaundice. Then we also look at the long-term risks to the infants exposed to in utero hypoglycemia. So I think this particular point may sometimes be underappreciated by our pregnant population, is that what the fetus is exposed to in utero can determine their metabolic future, if you like, or metabolic risks. So it can predispose those infants in utero that really have no control over their environment to future diabetes and obesity, which then leads on to the cardiovascular risks and multiple other complications. For the mother, the maternal long-term risks include a higher risk of type 2 diabetes, chronic kidney disease, and cardiovascular disease as well. So just explaining to patients why we focus so much on GDM may just pick out those things that may just show how important the diagnosis is and treatment if required for GDM. So getting to the actual numbers so that we can see what we're dealing with here. So we can see that the old is on the left side there, so up to 2025, and then on the right side of that table we've got going forward our new diagnostic numbers there. So it really is a very small change, 0.2 of an increase. So fasting plasma glucose is moving from 5.1 to 5.3 to diagnose diabetes. This is on an oral glucose tolerance test. And the 1 hour plasma glucose is moving from 10 to 10.6, 2 hour plasma glucose from 8.5 to 9. So on the right are the new diagnostic numbers. So I would predict it's going to be minimal change in percentage of patients that we see. I don't think it's going to have a great deal of effect on the actual numbers of patients we treat with GDM. I don't think it's going to reduce a great deal at all, but it's just going to sort of shift the goalposts a little bit so that we can have a bit more of a clearer idea of the patients that we need to be focusing on. So why has this change been necessary? Coming from the recent evidence of the trials that have just been complete, and every trial worth its weight has a great acronym. So the trials that the ADIPS actually reviewed and made their recommendations on were GEMS, HARPO, and the TOBOG. So they are reflected in there, and I've got the references at the back of the webinar if anyone needs to go and have a look at that. But it's quite nicely summarized in the AMJ article. The treatment at lower glycemic thresholds has been associated with a greater health service use, which I'm sure we've probably all mostly experienced. That's increased visits to maternity units being overrun, overwhelmed, patients that have been on that lower end, overserviced, using services, stressed about their numbers. There's also been an increased risk of small for gestational age offspring because of that tighter control, a lower lean mass, and increased risk of early term birth compared with women who weren't treated. So they've extrapolated and seen that these numbers are actually starting to mean something, that we can make these changes in our guidelines. 6-month follow-up of the infants within the studies demonstrated no differences in fat mass between treated and untreated infants. And other relevant trials haven't shown any benefit from early testing and treatment of GDM, including women with obesity in the United States and Iran. So there's a couple of different cohorts of patients that made up that group. So looking at how we now are going to be diagnosing our patients, diagnostic criteria is on the left-hand side. So gestational diabetes, these are our new numbers for gestational diabetes. On the right side, we've got diabetes in pregnancy. So that is now going to be referred to as overt diabetes in pregnancy. That's diagnosed at any gestation if one or more of the following criteria are met. So on the left-hand side there, that's basically just comparing the diagnosis for gestational diabetes. Now, on the right-hand side of that table, you can see that with our glucose tolerance test, those numbers are slightly higher than on the left on the gestational diabetes. We don't use the 1 hour level with the glucose tolerance test for diagnosing diabetes in pregnancy. We use the initial one and the 2 hour one. Now, also at any gestation during the pregnancy, if that HbA1c is above 6.5%, that is a diagnosis of diabetes in pregnancy. And a random plasma glucose of greater than 11.1 with symptoms, the thirst, the polyuria, that is associated or is diagnostic of diabetes in pregnancy. So we'll talk a little bit more about the diabetes in pregnancy and focus on that. But the focus or the emphasis of the guidelines has been to try and identify the patients with overt diabetes in pregnancy, stream them out so that we can then focus on them, managing them, and managing their care post-pregnancy as well. So with our diabetic classification, we've got GDM, and that's glucose intolerance with onset or first recognition during pregnancy. And that consists of an elevated blood glucose levels, which is less severe than overt diabetes. So that's those patients on the left-hand side of that table previously. And the patients on the right are the patients that present with hyperglycemia first detected in pregnancy that meets criteria for diabetes outside of pregnancy. So what we're looking for here is patients that have previously undiagnosed or pre-existing diabetes, and the definitive diagnosis of that diabetes can't be made until the postpartum period. So they require closer follow-up to make sure that we repeat their OG-TT after their pregnancy is complete and manage them appropriately. The additional management beyond that may be required for a lower abnormal blood glucose level may be required. So those patients with overt diabetes in pregnancy would be referred to your hospital as an urgent case much sooner, or as soon as that diagnosis is made, to get them into the hospital system under the obstetricians. So when do we do our timing of testing now? Is that still the same? Has that changed? With this particular point, I have referred back to the Queensland Health Guidelines and looking at who we test first. So who we test, the patients that we actually want to get a closer look at. With Queensland Health, they have got on their guidelines, and that summary is towards, that reference is at the back of the webinar as well, so that can be reviewed later. They have very specific risk factors for patients that should be screened for gestational diabetes. So, and with these risk factors that Queensland Health set out, of note there is assisted reproductive therapy and also ethnicity, and I'll talk about the ADIPS risk factors as well with the differences there. But it may just be something that you keep in the back of your mind and think that the patient may actually fall into this category. So if we have a patient with these risk factors, we're going to be doing a HbA1c less than 12 weeks. If there's no risk factors identified, they just go on to their routine care for a glucose tolerance test at 24 to 28 weeks. And then we'll talk later about if they're unable to complete their test or the test has declined. So if the risk factors are there, we really want to have a HbA1c less than 12 weeks to try and then define the patients and then stream them into whether they're overt diabetes in pregnancy or gestational diabetes. So looking at those risk factors and the patients that we actually test, ADIPS have a much smaller list of risk factors, and they do match up similarly with Queensland Health, except for that assisted reproductive therapy and the ethnicity. ADIPS don't actually mention any assisted or an ethnicity, but the rest of their risk factors do fairly much align. So yeah, we'll be looking at mainly previous GDM, obesity, overweight, family history. Those sorts of things would lend the patient to be having a HbA1c less than 12 weeks. So with our early pregnancy HbA1c screening, we're looking to identify and stream out those women with overt DIP, so we can then get them off to their obstetrician so that we can get them sorted and on their way with managing their glucose and risks. Now, special note here for services in areas, or health services in areas with a high background population or remote areas of type 2 diabetes. So those areas may have their own local guidelines that basically suggest that all patients have a universal HbA1c with their prenatal bloods or early natal bloods. It's a fasting blood test, nice and easy, and we can get that in sooner and get those patients out. So it hasn't been made a universal recommendation with ADIPS, but I can see in some rural and remote areas where it's difficult to get or plan to get an OGTT for travel and time and all the rest of it, that early HbA1c screening can really alert us to the patients that need that early care. So with patients that are unable to do a glucose tolerance test, if it's difficult, if they choose not to do it, some may not be able to tolerate it, the fasting plasma glucose is recommended. Important to just point out to patients that the diagnosis and treatment of gestational diabetes is supported by high quality evidence to have an oral glucose tolerance test, our 2-hour test. You can't exclude GDM without an OGTT. So we need to do that challenge test to exclude GDM. Women with fasting plasma glucose of greater than 5.3 in either early pregnancy or at 24 to 28 weeks should be diagnosed and managed as having GDM if they're unable to tolerate or do an OGTT. So that's one of the ADIPS recommendations. And in early pregnancy, women with a fasting plasma glucose less than 5.3, they can wait further screening at 24 to 28 weeks. But if they're above 5.3, we're really wanting them to treat them as a GDM. On the right-hand side of the screen, That's the alternative testing options that Queensland Health have presented. So it does align with what ADIPS is saying. Their presentation of that is just a little bit more probably clinician friendly in terms of looking at a reference easily, less wordy, that sort of thing. And it gives us very prescriptive or direct flow charts with what to use. So I always find that a bit helpful if you get a bit stuck with the patient thinking, oh, what should we be doing with this patient? So especially the patients that aren't the mainstream following the usual pathway types of patients. So just trying to summarize our recommended testing timeline into a nice succinct thought process for us. So on our first visit, what we're expecting when the patient first presents with a pregnancy, we're wanting to do their risk assessment, looking at their risk factors, plus or minus a HbA1c. So the risk assessment reveals any risk factors. We'd be looking to do a HbA1c. If there's no risk factors present, we would just be moving through and doing our universal OGTT at the 24 to 28 weeks. For at-risk women, they'd be doing their glucose tolerance test at 10 to 14 weeks. So this is probably quite a busy slide, but this is the ADIPS chart. And we're looking at that first antenatal visit, assessing for risk factors. If they're present, we then want to have a HbA1c. Now, if they've already had a HbA1c, we can use one if it's been measured within 12 months. So we can use that previous result. If we've come back with a HbA1c of greater than 6.5, those patients get streamed into the over-DIP pathway and no glucose tolerance test is required. The way that this flowchart is set out is our overt dips are all on the left, and then on the right we have the no diabetic patients. So HbA1c with initial antenatal blood test in the first trimester, HbA1c of greater than 6.5, overt dip off to our tertiary healthcare or early referral. If we've had previous gestational diabetes or the local policy excludes that, we would be having our glucose tolerance test before 20 weeks, ideally between 10 to 14 weeks. If we reveal an overt dip in these patients, they get referred off early. Then we stream our other patients into early gestational diabetes and then non-diabetes, repeating our glucose tolerance test at 24 to 28 weeks. If we then stream patients further into overt dip, gestational diabetes or no diabetes. So from there we can, even though it is a bit of a busy flow chart, it gives us a better idea of where to fit the patients in terms of management and what we should be treating them or how we should be treating them. So this didn't translate so well in terms of clarity there, but this is just a screenshot of the Queensland Health flowchart, and you can access this in much clearer form with the resources. And this just gives us, it's actually quite a good resource, and it just gives us the risk factors, alternative screening options, and what we'll be doing, where we'll be doing it, and how we then stream them in terms of their overt dip and GDM as well. So moving through to more holistic care that the ADIPS have, or the reasons for these changes. They've looked more at consumer experiences and especially stigmas that are involved with GDM for patients. So it seemed that the patients that were being diagnosed with GDM at that much tighter control were feeling quite overwhelmed with what was expected of them. There was a lot of fear, shame. Now what we're looking for is more positive influences. So in terms of how we present this and how we engage patients with these diagnoses and testing and things that need to be done in early pregnancy, we're looking to create more of a positive experience and outcome for the patient. So a diagnosis of GDM may actually affect a patient's psychological well-being. It may be a catalyst for positive behavioural change and improved quality of life. So it can be a good educational turning point, especially if it is a first pregnancy, for a patient to realise that maybe some lifestyle choices could be improved for the sake of them or the future health of their infant as well. So that's viewed as the positive changes or positive spin, if you like, that we're going to encourage our patients to view this with. The negative is always a bit bigger, always a bit more points for a patient to realize. So they may experience internalized stigma, such as the guilt, shame, fear, and anxiety. Externalized stigma, so when they go to the local maternity hospital for their shared care, they're in the diabetic section, and the patients that aren't diabetic are over in the other section. Labeling, discrimination, depersonalization, and judgment have all been revealed as negative experiences for consumers with healthcare providers. So also the burden of care that can be included, such as increased surveillance, finger pricking, monitoring, what have I eaten, why is this high, dietary restriction, financial strain. All of that can lead to a reduced quality of life and negative pregnancy experiences that can then persist postpartum. And those studies that ADIPS have based their recommendations on have drawn some of these concepts out. So we're wanting to recognise the importance of person-centred, culturally safe, holistic care. We are trying to encourage the mothers to be active participants in decision making so that they can feel in control of their pregnancies and choices, presenting them with evidence-based, culturally and linguistically appropriate materials about the rationale for GDM testing, and sort of demystifying it. Most mothers get the horror stories about the 2-hour glucose tolerance test that someone had to have, couldn't tolerate it, made them very unwell. Yes, it is possible, but it's there so that we can provide better care and for both mother and baby for their pregnancies. So we'll apply some of that knowledge. As I said, this evening's webinar is basically just on streaming those patients into their diagnosis and where we go to from there. So we'll look at our first case study, and that's Maria. So Maria, she is 37 years old, Maori ethnicity, and she's a G2 P1 at 9 weeks presenting. We need to look at her history and her risk factors to see where she's sitting in terms of her diabetic risk or GDM risk. So she has a BMI of 34, and in her first pregnancy, she also had prior GDM. There's a strong family history of type 2 diabetes as well. So if we look at the Queensland Health risk factors for GDM, she's ticking a few boxes there in terms of previous GDM. She's 37, so maternal age is okay. Her BMI is over there, family history of diabetes, and so Pacific Islander. And we've also had a previous GDM as well, so with a prior GDM. So she well and truly ticks a few boxes in terms of risk factors. Patients only need to tick one, and then we are sending them off to have a look at what we're going to do now that we've identified her risk factors. So we should be doing a HbA1c with Maria if it's not already been done. We'd be doing that with her bloods, her screening bloods, one of the fasting bloods that we can get done quite easily. And from there, we can then stream her into low, medium, high risk, where we put her and treat her. So she's now had her HbA1c, and that's returned at 6.6, which puts her just into overt diabetes in pregnancy. So for the term of this pregnancy, we will be treating Maria as a diabetic patient, and she will be referred off to our local hospital maternity unit as a higher risk with diabetes, and they will be taking care of her and managing her as a diabetic patient, which is different to gestational diabetes. So she now meets the ADIPS criteria for overt diabetes in pregnancy. Her management will be specialist referral, glucose monitoring, education, dietary management. From there, if she needs anything else, that will be managed by the obstetricians maternity units, and she also doesn't need a glucose tolerance test at this stage because we're treating her as a diabetic patient. Now, with our next lady, we have Amira. She's a little bit younger, 29 years old. She's primigravida at 18 weeks. And we're going to first start off looking at her risk factors. So she has no GDM risk factors. Her BMI is 23. There's no family history. So referring back to where she's sitting in terms of risk factors there, nothing on that list is being highlighted. So she just passes through to routine care at a glucose tolerance test at 24 to 28 weeks. So she doesn't have to have her HbA1c at less than 12 weeks. Her glucose tolerance test now has come back at 26 weeks with a fasting plasma glucose of 5.4, 1 hour test 10.7, and her 2 hours at 8.9. So where are we thinking that puts Amira in terms of diagnosis of overt DIP, GDM? She actually just scrapes into the GDM category there, or criteria, with her fasting plasma glucose at 5.4 and her 1 hour plasma glucose at 10.7. So yeah, she's basically in GDM, which you probably wouldn't have predicted when we first met her with her risk factors to see how she was going to be going with that. So her management will end up being dietitian referral, self-monitored blood glucose levels, and lifestyle interventions. So we can also send her off to the obstetricians. She isn't as high risk, but still needs to be managed appropriately. And the hospital will still, or the maternity unit, will still want to know about Amira so that they can manage her growth and ultrasounds and have everything all up to speed and all of her screening and everything in place. So in summary, the idea is that we're trying anyway to keep things very simple. And I think the big takeaway is to think about gestational diabetes or diabetic screening at that first antenatal visit. So it's no longer something that we would put off down the track to 12 weeks or something like that, or 20 weeks, 20-week OGTT. We're actually looking to screen those patients at the first visit, whether they're into that overt DIP or whether they're into a gestational diabetic cohort. And also that gives us the trigger, if you like, in early pregnancy to just open the conversation about gestational diabetes, things to look out for, risk factors, and also the long-term complications for mother and for baby moving forwards through their pregnancy. So I think that completes our education tonight. That's our reference slide, and those links there will take you to those really quite useful guidelines and tools to be able to use. We'll throw back to Campbell to see if we have any questions or concerns and a bit of a discussion about tonight's webinar.
Well, wonderful. Well, thank you, Simone, for that insightful presentation. You certainly covered a lot of ground in there. We had a couple of questions pre-asked before the webinar, so we might just cover a couple of those, Simone, and they might.
Yeah, sure. I'll just move back to our guideline. There we go. I'll move back to that as a reference point. Yep.
Fantastic. Thank you for that. So one of the questions that came in earlier was managing overweight before pregnancy. Can that help in reducing the risk of GDM?
Yes, definitely. It definitely can. And although it's not really covered in these guidelines so much, but if patients can come to see us for pre-pregnancy planning, that is an ideal time to even start talking about gestational diabetes, the risks, the long-term complications, And also it's a good time to get that weight into a healthy BMI so that we can reduce the patient's risk factor. Larger percentage of patients are either having their gastric sleeve surgery or weight loss surgery, being exposed to medications such as semaglutide or tirzepatide to gain weight loss. Even that bit of weight loss can reduce their risk of GDM and diabetes, and overall, it is a really excellent way to plan for a pregnancy. As well as stopping smoking, reducing drinking, there is no safe level of alcohol intake during a pregnancy, which basically means no drinking during a pregnancy, and any sort of assistance that we can give with stopping smoking as well is a huge benefit for these patients.
Excellent, thank you. There's a question here, should we monitor the first year after delivery?
Yes, we should monitor the first year after delivery, even though it's not so much covered in this guideline as such. I think the Queensland Health, I tried to keep it a little bit more concise in terms of what we covered tonight. The Queensland Health resource is comprehensive in terms of postpartum, what we do with patients there, but definitely if they are GDM or diagnosed as GDM, we want to do an oral glucose tolerance test at about 6 weeks, which is a really difficult time for any new mum to be doing a 2-hour test at 6 weeks when they're meant to be having their postpartum check, baby's first immunizations, probably partners, families going back to work, things settling down. So it's a really challenging time. If we can't get a glucose tolerance test for those patients, those GDM patients, a fasting or HbA1c is adequate, and going forward, even with GDM patients, they would be monitored annually anyway. So fasting glucose is, if that's all we can get, that's great. Fasting glucose every 12 months for about, I think the guideline is 5 years postpartum, but you'll easily see it with that and with subsequent pregnancies as well.
Excellent, thank you. A couple of questions have come through from the listeners, and tell me if this is outside the scope of this talk, but someone writes, new CGM monitors aimed at T2DM Dexcom 1 Plus. Is there a role in diagnosis management of GDM?
Not so much in diagnosing patients with their glucose monitors. I'll cover a few things here because I think what the question's aiming at is when do we use the continuous glucose monitoring in diabetic patients? Some healthcare services, Queensland Health, will fund that for gestational diabetes. It's not recommended in the guidelines, but some healthcare services will provide those patients under their diabetic educators. And if they are a diabetic patient, they will probably be given a continuous glucose monitoring. They're quite expensive units. I think the last price I was aware of was $5,000 to $6,000, but that could have come down a bit now. So the local healthcare services will decide the patients that are using the continuous glucose monitors or the CGM. If a patient is already using a CGM when they fall pregnant, they would already be under a higher risk tertiary obstetrician with the health service anyway. So I think what I'm trying to say is if they already have a continuous glucose monitor in use, they're already probably higher risk, but we wouldn't use that to diagnose a gestational diabetic. We would still refer back and do a fasting HbA1c just for the accuracy. Hopefully that's answered that question.
Wonderful, thank you. And another, perhaps slightly outside the scope of this, but Raina2 from a long way away writes, hi, thanks for the presentation. I'm a GP from Cameroon. There we have just glycemic index and glycated hemoglobin. How can I manage those during pregnancy?
So I think the HbA1c, the glycated hemoglobin, would be equivalent to our HbA1c. So if you don't have access to an OGTT, which is the 2-hour glucose tolerance test, you would just have to defer back to your HbA1c levels and go from there, depending on what facilities or what resources you have at hand in terms of those levels of gestational diabetes, whether the patient then goes into being treated for just lifestyle modifications, so diet, exercise, self-monitoring with a glucometer versus pharmacological treatments such as metformin, or whether they need insulin or that sort of thing, depending on how those levels are sitting. If all you have is a HbA1c, that's as good as anything else, as well as a glucometer, a self-glucometer. So that still gives you pretty good control, and I think the guidelines would give you enough out of that to actually make that diagnosis safely with only a HbA1c to rely on.
Excellent. Abul writes, does change of thyroxine dose helps to prevent development of GDM?
Not that I'm aware of. I didn't come across any correlation of that in the information. So no, I don't think changing the thyroxine dose would have any influence on the diagnosis of GDM at all.
Okay, great. An anonymous attendee asks, Medicare restrictions versus HbA1c, GDM and postpartum period.
Yeah. So that is something to consider and something to be mindful of. And with all of our pathology now, I think we are guided towards writing a little bit more in the clinical notes as to why we're wanting that HbA1c or why it's relevant and why it should be bulk billed. So yeah, definitely if we can't access it, I don't know if you can access a previous HbA1c through the patient's My Health record or something like that. If you don't have any access to any of that, or you're not sure where the patient sits, you've really got no choice but to repeat that HbA1c or do a HbA1c. And in the clinical notes now, it's always just a good habit for Medicare restrictions and funding to, even just write the reason for that testing. So early pregnancy, query, risk factors, GDM, needing to define where the patient's sitting. And I think it would be highly unlikely that the patient would be sent a bill for that HbA1c.
Okay, great. And I wonder, maybe taking us right back to the start of your presentation and the research, there was a question, why is GDM common? I think you had some data, maybe just to help round out the conversation, just to reflect back on some of that data.
Sure. I think it is common in terms of the changes, as there's a couple of factors here. So the changes in population anyway, so increasing BMI, increasing maternal age, also within Australia, because these are Australasian recommendations, we've had a change in ethnicity, so a higher representation of South Sea Islanders, Southeast Asian patients as well. So that has increased overall our GDM patients. Combined with that, we've actually since 2014, we actually reduced the threshold to diagnose GDM. So it was nearly like a whole catalyst and explosion of GDM diagnosis of patients that seem to be just creeping into that threshold of diagnosis of GDM. That did create a lot of anxiety and undue stress for patients that were otherwise risk-free, no concerns, no previous GDM in previous pregnancies. Now, all of a sudden, we're treating them as a high-risk GDM patient with a HbA1c or with fasting glucose of 6.7 or just over the top, and getting them to prick their fingers and change their diet. And that then seemed to cause a rebound effect in the size of the infants and the pressures on healthcare services and over-servicing and things like that. So what the research has showed us is hopefully with these new guidelines, we can not jeopardize patient safety and outcomes. We can also provide a more pleasant or reassuring experience for patients so that they don't feel that stigma by closer or more accurately diagnosing a GDM patient with regards to the risk factors and their complications going forward. So overall, I suppose what we're trying to do is narrow down to the population that has the highest risk, rather than getting that outlier of patients that are very, very low risk and then overwhelming them with intensive diabetic education control for not much outcome or not much yield. So I think, yeah, we're just getting to have a more realistic population and numbers with which to treat in terms of the outcome.
Wonderful. And that brings us to the conclusion of this evening's webinar. Thanks again for all of those insightful questions. It's been a very engaging discussion. A big thank you to Dr. Simone Gonzo for taking time out of your busy schedule to share your experience. And thanks to everyone for joining us. And we hope to see you at our next webinar. And thank you once again, Simone.
Not a problem, Campbell. Thank you, everybody.